Hi everyone, my name is Mariam Heather. I'm second year internal medicine resident. The topic I choose for my research and the one I am presenting today is the role of sociodemographic factors in malignant neoplasm among liver transplant recipients and the associated mortality and hospital burden. Liver transplantation is the second most common organ transplant after kidney transplantation. Recipients of liver transplants are at an increased risk of developing de novo malignancies than the general population. In 2017 alone witnessed 8,000 liver transplant, and in 2016, 80,000 adults have been living with the functional liver grafts. Post-liver transplant complications, as we all know, are acute or chronic graft rejections, adverse events associated with immunosuppressive medication, and recurrence of the primary liver diseases. Long-term immunosuppressive agents are required post-transplantation. However, their main adverse effect consists of developing malignancies. So far, few epidemiological studies addressed outcomes in post-liver transplant patients. To the best of our knowledge, such as the annual number of hospitalization, mortality, patient characteristics, and malignancies. So, the aim of our study was to determine the nationwide prevalence of malignant neoplasm, the associated trends in patient hospitalization, and the risk factors in liver transplant patients. Our study revolved around patient population who received liver transplant and diagnosed with any malignancies. The study compares sociodemographic factors including age, gender, ethnicity, their socioeconomic status. This study also includes their mortality, in-hospital stay, and cost utilization. It is a retrospective case control study. Our data source include National Inpatient Sample Database, collected between January 2016 and December 2018 to select hospitalized patients with a primary or secondary diagnosis of liver transplant with an ICD-10 codes. A little introduction regarding the database. The NIS database houses more than 7 million records per year. It is the largest all-payer dataset from the Healthcare Cost and Utilization Project. Our main limitations include that this study only revolved around inpatient and we did not have outpatient data, and we were unable to comment on the exposure, cause, and duration of disease. All malignant neoplasm were also identified with the ICD-10 codes and were categorized into head and neck, GI, excluding liver, bone, skin, breast, etc. We identified 26,225 liver transplant patients. The population was divided into case and control groups depending on the presence and the absence of the malignant neoplasm, except for the hepatocellular cancer, as HCC presents the most indicative criterion for liver transplant. Thus, we excluded it from the cases to avoid bias. A total of 1,909 admissions were associated with the malignant neoplasm, which count as our cases. The primary outcome included the prevalence of malignant neoplasm and the corresponding correlation with sociodemographic risk factors. The main variable we studied include hospital characteristics including age, sex, race, socioeconomic status, admission type, admission day, hospital bed size, location, and region. The secondary outcome consisted of analyzing the hospital utilization, including discharge status, inpatient mortality, length of stay, and inpatient hospital-related total cost. We performed group comparison based on sociodemographic characteristics using student t-test for continuous variables and chi-square test for categorical variables. All hypothesis testing used a two-tailed p-value with a significance level set at 0.05. Factors which affect our analysis include a caveat of the administrative nature of the database. Since we don't have a follow-up on individuals and we did not know if they were transferred to any other hospitals, and the duration between their transplant and the diagnosis of malignancy. So now moving towards my results. First of all, I would like to talk about the admission rates. Lymphomas were the most prevalent cancers among liver transplant patients, followed by respiratory and GI cancer, which exclude liver or hepatocellular cancers, and then leukemia and head and neck cancers. Cardiac cancers were the least prevalent, followed by the cancer of the nervous system and bone. Coming toward the patient's demographics. Overall, malignant neoplasm with the liver transplant were more frequent in older patients with a mean age of 61.21 years and among males. Respiratory cancers were the most prevalent malignant neoplasm among the whites, followed by lymphoma and GI. Among Black patients, respiratory cancers, reproductive cancers, and leukemia were the most reported. Among Hispanics, lymphoma and GI cancers were seen. Regarding inpatient cost and hospital utilization, most hospital admissions were non-elective. More patients were admitted on weekdays. Patients with malignant neoplasm, mean our cases, had a higher length of stay compared to our control group. Similarly, cases had a higher inpatient hospital cost of care than our control group. Bone cancers had highest hospital cost. Moving toward the mortality, respiratory cancers were the one with the highest in-hospital mortality. Now, to summarize my important result and to conclude, I would say that significant association had been seen between liver transplant patient and malignancies. Important associated factors were increased age and more common in males, mostly seen in white people as compared to Black and Hispanic population. And higher mortality has been reported in our case group as compared to our control group. Most critical malignancies which required hospital admissions were lymphomas, lung cancers, and GI cancer, though there are other studies which report skin cancer as the most prevalent cancer. But our research found that it was not seen in the inpatient hospitalized population and was less aggressive, requiring mostly outpatient care. So, I must say that cancer screening is most crucial in early detection, specifically in post-liver transplant population, and this can reduce mortality and hospital burden and improve patient outcomes. Thank you.